Good afternoon. And I'm excited that we have an hour to talk about PrEP and then answer some questions that folks might have. So let's just go ahead and get started because we have quite a few cases we wanted to go through today. All right, so I have no financial affiliations. And we hope to talk about some epi, talk about the different scenarios for PrEP, and talk about the impact of STIs, and also touch on U equals U. We do a lot of education with our providers within the San Francisco Department of Public Health, where I'm actually primarily based, both locally in San Francisco and in surrounding communities. And STIs continue to come up as a reason for people not wanting to offer PrEP. And so I wanted to make sure we touched on that. So just to review some of the CDC slides, and I really bring these up to highlight the populations where we have the largest epidemic and where we're actually missing PrEP initiations and persistence. So 2/3 of all the new infections are among MSM, and in the United States, it's predominantly among African Americans and Latinx individuals, both for men and for women. And when the CDC has looked at the uptake of PrEP using pharmacy data, it's actually 70 to 75% white males. And that is not where the epidemic is in the United States, and so we have this large gap. And the concern is always that PrEP might exacerbate existing racial ethnic disparities, and then without a concerted effort, we won't close those gaps, but we'll widen them. And as we see essentially that PrEP HIV infections are happening predominantly among millennials, so those under the age of 35, so ensuring that our efforts for outreach and structure of services meet the needs of a population. 10% are over the age of 55, so we can't ignore those individuals who are older, although the age of older keeps dropping down to 40 now in some places, some discussions, but just keeping in mind that we actually have to ensure that we're making sure our services are meeting the needs of young people as well. And this is an epidemic predominantly in the South. We're going to talk about the epidemic in the focus cities and the focus states, but these are graphs that many of you are familiar with, and most of your clinics are probably in one of these deep purple places. So the first ARS question is about same-day PrEP initiation. So do you start PrEP on the same day or wait for test results before prescribing? So A is same day, B is wait, C is something else. Great. So about 41% suggest same-day starts, and more than half wait for the test results, and 7% would do something else. So I just wanted to highlight these data from New York City, where they evaluated what happened when you started PrEP immediately versus waiting to start PrEP. And so the vast majority of individuals who started PrEP in their sexual health clinics did do so on the same day. And when they looked at chart reviews, if they had medical contraindications to PrEP or had lab results that would have contraindicated them starting PrEP, only 0.3% had an absolute contraindication to have not started PrEP, and 0.4% had a relative contraindication. And the vast majority of those who delayed PrEP had no contraindication to starting PrEP. And I think the sobering thing is that a very small proportion started PrEP later. So I think the take-home away from this is if you have somebody in your office who is interested in PrEP and willing to take PrEP, having them come back is you're going to lose a lot of people. And I think we've seen this in our clinical settings. I think when you refer people to outside places, that's another place where we can lose individuals. And then now we're starting to get more data that you can do this in a way where you just screen for acute HIV, any symptoms that individuals have, and then draw the labs, start PrEP, and then follow them up. And this does not put the patients at increased risk. All right, so shifting gears, when you prescribe PrEP, how do you prescribe it? 1 month with a return in 1 month for refills, 3 months, asking the patients to come back for refills, 3 months with refills, 12 months, or the sky's the limit. Great. So the vast majority would give 3 months with requiring the patient to come back in for refills. And so about a quarter would actually require the patient to come back every month before giving refills. So let's go through the Goldilocks problem with PrEP prescribing. So this is something that we've looked at in our clinics, and it's the balance of giving sufficient quantities so that individuals don't have difficulty with adherence and persistence. And when we looked at our primary care providers, we found that prescriptions associated with 30 days or less were actually associated with a higher rate of PrEP discontinuation, which is not that surprising. However, when we did look at what the testing was for individuals who were on PrEP, only about 2/3 had HIV testing in follow-up, even when we made the sort of intervals more forgiving at 4 months. And we had actually about 20% of people who actually never had HIV testing. So it's not PrEP in the wild, but we do want to provide people with the options and to create some flexibility. And then we also looked at some panel management strategies. We've also been evaluating the idea of having people use telemedicine, so just come in for labs without requiring them to come in for follow-up visits, but creating some flexibility. But the requirements for follow-up testing, I think, are essential, but just ensuring that we don't hamstring our patients in being able to continue on PrEP. So question number two. Case number one. So it's a 21-year-old woman who asked for PrEP. She says she always uses condoms with her sex partners, but would like to stop using them. So what do you recommend? You don't offer PrEP because condoms have worked well for her. You don't want to risk STIs. You don't offer PrEP because it doesn't work well in women. You offer PrEP but tell her it works less well if she has BV. You offer PrEP and counsel her that condoms will prevent STIs, but leave it up to her. Great. So you offer PrEP and counsel that only condoms will prevent STIs, but leave the condom decision up to her. So that is absolutely the most patient-centered and correct answer, I would say. So just to review the CDC guidelines for heterosexual women. So these are the summary from the 2017 update, and heterosexual women and men are in the center. And I'd just like to highlight that in a high HIV prevalence area or network is an indication for PrEP. So it's a recognition that even despite low individual risk, if somebody's in a high prevalence or area or network, that alone could be an indication. And I think it might go a long way to destigmatizing PrEP is only for individuals who are at high risk, and that by offering PrEP, we're somehow subjecting that individual to a label around their high-risk sexual behavior. And the question often comes up, actually, given some of the studies around PrEP efficacy in women about does it really work in women? So this is from AVAC, and it plots on this, on the x-axis is a percentage of participants who had detectable drug levels, so essentially adherence, with high adherence on the right, and then effectiveness with high adherence at the top. And so in the upper right corner are many of the MSM, studies among MSM. So these are the EPRGAY study and PROUD, which showed both high adherence and high effectiveness. And then there's IPREX in the middle at about 44% efficacy. And then in heterosexual discord in couples, there actually was a very high efficacy, and there was also high adherence in those studies. And then there are several studies of heterosexual women where there was no efficacy or actually negative efficacy in the VOICE trials, one of the arms of the VOICE trial, which has led many people to ask the question of does PrEP work in women? But I think this highlights that there's a linear impact on effectiveness based on adherence, and the adherence was very low in those studies. And understanding what the context of why those women did not take PrEP in those studies, I think is going to give us a lot of insight into how to roll PrEP out in general. So to look at this question, there's been several meta-analyses that have sort of tried to answer this, and this is a result of a meta-analysis that indicates that if it's taken regularly, yes, that PrEP does work, that adherence and efficacy estimates might be different than among men who have sex with men or individuals who have exposure via anal intercourse, but that you can see in the bottom with higher adherence that the risk ratio, relative risk, is actually closer to about 75% reduction in HIV acquisition risk. There are some PK data that indicate that there's 10 to 100-fold lower levels of tenofovir in vaginal and cervical tissue compared with rectal tissue, and that tenofovir is cleared more rapidly from vaginal than rectal tissue. And so that more adherence or higher adherence is may be required for women. PrEP is very forgiving for MSM, with 4 doses per week being associated with high adherence, and is likely less forgiving for women. So higher adherence to maximize efficacy is essential. All right, so case 2. This is a 34-year-old man, MSM, has sex with new partners approximately twice per month. He doesn't want to take a daily pill because his sexual exposures are relatively infrequent, but he also doesn't want to use condoms. What would you do? Encourage him to use condoms. His exposure is relatively low, so he doesn't actually even worry about PrEP. Encourage him to take PrEP daily. Have him start PrEP 7 days before he plans to have sex, or prescribe on-demand, or what's sometimes referred to as 2-1-1 PrEP, even though it's not FDA approved. More than half suggested on-demand PrEP, even though it's not FDA approved. 38% would counsel to take PrEP daily, and 6% would suggest either starting 7 days before or encouraging to use condoms. So I'll touch on all of those. So Ipergay, which has one of the best names in our PrEP trials, is really about taking PrEP 2 to 24 hours before anticipated sex. So thinking about if somebody's able to plan or become very creative in delaying sex if the opportunity presents itself, and then taking 1 pill 24 hours and then 24 hours after that. And then if there's more sex, there's more pills. And so this 2-1-1 can become 2-1-1-1-1. Depending on, what type of weekend it was. And so this is something that we found has been really appealing for individuals who are not interested in taking a daily pill. If they have sex a couple of times or a few times a month, they don't want to be necessarily on a daily pill, even when they're not having sex. So these are the data that support this from Ipergay. So this is a large trial that was done in France and French-speaking Canada. And it had a very high incidence in the placebo arm of about 6 HIV infections per 100 person years. And it had a 97% relative reduction ratio versus placebo. So it has a very low number needed to treat as well. And the median number of pills that were taken in this trial were about 18. But the question came out is that the men in this trial were having a lot of sex. And the question came up in this scenario, if somebody's having less frequent sex, does this actually protect? And so in the overall Ipergay trial, they had about 10 sex acts per month and took about 15 pills during that time. In the sub-analysis, there was about half the frequency of sex and slightly lower, but not quite half the number of pills taken. So even though their person years of follow-up was much smaller, they actually did not see any HIV infections in those who were on this regimen with less frequent sex reported, and the incidence was similar to the placebo arm overall. So it does provide data and suggestion that this actually does work for individuals who have sex less frequently, and that the impact in Ipergay was not just because people were taking a lot of pills anyway, because they were having a lot of sex, so they were essentially on daily PrEP with lower adherence. So the CDC currently recommends daily PrEP only. It's only licensed by the FDA for this indication. IAS USA does recommend 2-1-1 as an alternative to daily PrEP, and daily PrEP, for some of the reasons we talked about, is only recommended option for cis women and people who inject drugs. I think that for trans women who are having anal sex only, that 2-1-1 would be an option. It's not something that's been studied. There are very few to no trans women in the Ipergay trials, but we don't have any suggestion that the PK would be any different for trans women, although there may be some implications for gender-affirming hormones. So there's a lot to consider because we do know that about 30% reduction in tenofovir levels that occur with some of the gender-affirming hormones. So we have had a lot of efforts to evaluate whether 211 might be effective in increasing uptake. And in one of our sexual health clinics, it's actually often offered even-handedly to patients who are coming in to access PrEP. And there's about 30% of individuals who decide that that's the primary option that they want to use. And then they actually subsequently flip to daily and then flip back. And some individuals on daily decide that they want to do 211 depending on their seasons of risk. So this is how we sort of think about it. So who can use PrEP daily and 211? So daily PrEP is really for anyone. And 211 has only been studied in MSM. For chronic Hep B, daily can be safely used, but 211 can trigger a flare. There's some planning that's required for 211 versus daily where there's really no planning needed. And this idea of forgiveness. So 211 is less forgiving or not forgiving compared to daily PrEP, which has more forgiveness, particularly for MSM. All right, so question 3. A 48-year-old MSM with hypertension comes in requesting PrEP. He has multiple partners, frequent sex and frequent STIs. His creatinine is 1.7 and creatinine clearance is 61. What would you do? Prescribe daily TDF, prescribe daily TAF, prescribe every other day TDF, prescribe 211 TDF, tell them to use condoms. Great, so very TAF aware. So just want to review some of the renal effects of Truvada or TDF. I think with the approval of TAF that there's been a reevaluation of some of our approaches to using TAF, both in treatment and also as we consider how or if we're going to use this for PrEP, given the data now that we have from the Discover trial, which I'll touch on in a second. So just to step back and look at the renal effects of TDF, in Olay and in the Kaiser study that there was a risk for negative renal effects, particularly if the EGFR was less than 70, if somebody had a baseline EGFR that started out below 90, or if they were older, so over the age of 40 to 50 years old. In Partners PrEP and Partners Demo, that there was no difference in renal effects in follow-up testing, that most of the creatinine clearance changes are transient and not confirmed later. And in the Thai IDU study, they actually saw no effect on creatinine, and that this seemed to be age dependent. And when stopping PrEP, the creatinine often reverted back to baseline, and in both clinical, I think our clinical experience, and in the trials, rechallenging individuals has often been successful. And so IPERGAY actually has looked at this idea is lower exposure to TDF associated with lower risk of having a EGFR change. And the bottom line was, yes, if you had fewer than 15 pills in the IPERGAY study, you had a lower change in your EGFR compared to those who were taking it more regularly, which is not that surprising. And now we have Discover. So Discover trial was a trial of about 5,000 MSM in the US, Canada, and Europe. And two caveats to the Discover trial is that it really under-recruited African Americans. There was very low proportion of African Americans in the trial, and there were very few trans women. And there were, of course, no cis women in this trial. But this was a non-inferiority trial, and it met its non-inferiority benchmarks. As you can see, there were 15 infections in the TDF arm and 7 infections in the TAF arm. And so it met its non-inferiority outcome for the primary. There was no difference in adverse events or adverse events that led to discontinuation. They also looked at the renal safety data. This is 48-week data. 96-week data actually just came out from the study in Europe, which essentially shows the same findings, but there was a small difference in eGFR calculations for the TDF arm versus the TAF arm. And if you look at the percentage and the changes, these are, coming to like 2 or 3 creatinine clearance points with a group that's young and has a creatinine clearance that's high. So the clinical relevance of this, I think, is questionable. And they did not see any serious difference between discontinuations. The other aspect of DISCOVER, which is now coming out in the 96-week data, is that there was a 1.7 kilogram weight gain in the TAF arm and a 0.5 kilogram weight gain in the TDF arm. So when I'm counseling my patients on potential side effects, I also include the fact that weight gain is higher in the TAF arm compared to TDF, which has some impact on whether or not they want to switch. So this is the data from IPREX that looked at what was the incidence among individuals based on the number of doses that they took per week. This is based on dry blood spots, so these are average doses in a month, and that essentially if somebody was taking 7 pills a week, that estimated efficacy was 99%. If it was 4 pills a week, it was 96%. And if there were 2 pills a week, the estimated efficacy is still 76%. So remember overall in IPREX that the efficacy was about 44%, but this is the forgiveness that TDF has for MSM. And the question that I wanted to also touch on was this STIs and the efficacy of PrEP. So in several RCTs, there's been no evidence that having more STDs was associated with a decrease in the efficacy of PrEP. And that was both in IPREX and in Partners PrEP. And in open label studies in PROUD, there was no difference in the efficacy of PrEP. In the PrEP demo study, there was no efficacy change from PrEP. And what I tell providers is that if you're not seeing a lot of STIs, you're not reaching the right population. That we are seeing this resurgence in STIs, and I think that there's this desire to attach that resurgence to PrEP, but it actually predated PrEP. In San Francisco, we've seen this decoupling of the HIV epidemic from the STI epidemic, so we've seen a rise in STIs before PrEP was available, even as we saw a decline in our HIV diagnoses, and that with increased screening and with reaching the populations who might not be coming in for regular testing, that we're going to be seeing a lot of STIs. So the opportunity to diagnose and treat STIs actually, from some modeling data, suggests that we could reduce incidence of chlamydia and gonorrhea by 30 to 40% just by more frequent screening and treatment of asymptomatic infections. And so I think we should expect to see STIs if we're reaching a sexually active population that has a risk for HIV, and that we have been able to turn the curve in HIV with the use of PrEP in many places because we have PrEP to be able to do that, and that we also need to consider what's needed for STIs. And we have some studies that are looking at doxycycline and its impact on syphilis and chlamydia. There's a vaccination that might have some efficacy for gonorrhea. And so thinking about what are the biomedical interventions that we might need for STIs in addition to PrEP, and not allow concerns about STIs to undermine our efforts to get PrEP to those who might most benefit. And so this is some data that's looked at the effect of PrEP on STIs. So the bacterial STIs are increasing over time, but to highlight that this predated PrEP, and that there is some risk compensation among individuals who are on PrEP. For a lot of individuals who have risk for HIV, their primary driver for condom use is concern about HIV, and if PrEP alleviates that concern and then anxiety, which I think has positive sexual health impacts, that there's likely going to be less condom use. So we suggest recommending screening every 3 months. I actually have some patients who I screen every month. I write standing orders and tell them just come in and get tested and treated. And those are also some people I might consider offering Doxy to. And so thinking about how we can actually turn the curve for STIs and not use it as a reason not to prescribe PrEP, which I think is happening. All right, so switching to case 4. So it's a 29-year-old MSM in a serodifferent relationship with the HIV positive partner who comes in requesting PrEP. He explains his partner is fully virally suppressed. He's been for over a year, but he would feel more comfortable being on PrEP. So would you prescribe PrEP? Prescribe it for now with the hope of eliminating in the future. Tell the patient he doesn't need PrEP because U equals U. And what is U equals U? Great. So 71% suggest prescribing PrEP. 25 would prescribe now with the hopes of eliminating in the future if this partner remains suppressed. Tell him 4% suggests he doesn't need PrEP because U equals U. So I think the right answer is prescribe PrEP. This question stem didn't get too much into the weeds. But I think that even with it, so I'm going to talk a little bit about the U equals U data, but there were HIV infections in both HPTN 502 as well as in the Partners PrEP and some of the other trials, so that there are outside partners that patients have, and that the request for PrEP might be an indication about that, even if it's not explicitly stated. And I will say that most providers are probably not explicitly asking about it. So we take the approach, if somebody's asking for PrEP, then we give them PrEP because there's probably something going on that they're not telling you, and that they're trying to be proactive. So I think that the seasons of risk is something that's talked about. So does somebody have risk now, and then does that risk change later? I live in San Francisco. It's always spring. And so we try to take people where they are and understand that there might be times where they don't think that they're at risk, and that, but they truly still have risk going on. And that subjective self-assessments of risk among MSM is universally poor. And so whenever we compare objective measurements to what individuals perceive their risks are, that there's a tremendous discordance. And we've seen eight HIV infections among our PrEP cohorts who have discontinued PrEP. And when we've talked to them, many of them felt like they were no longer at risk for PrEP. And so we have to balance patient-centered approaches with the reality that we want to encourage individuals to use all the tools that they have at their disposal. And PEP is underused as well, so not to forget about PEP. And most of our PrEP clinics are also PEP clinics now, because you're going to identify individuals who have risk, who either discontinued PrEP or are trying to initiate it. All right, so just a quick overview, 052, I'm sure everyone's well aware of this. And so there were 3 infections in the immediate arm and 43 in the delayed arm, with the efficacy of 93%. I love to show this data because these were the couple studies that looked at MSM and provided the data for us to really push U equals U. In the bottom, there is 0, 0, 0. Like, there are very few trials where we have seen, and for prevention, 0, 0, 0. Not even the PrEP trials. There were infections in all the PrEP trials. And so this is a powerful statement that I use with my patients to say that if you are virally suppressed for, at least on treatment for at least 6 months and virally suppressed continually, you can use condoms for pregnancy and STI prevention, but you do not need to use condoms for HIV prevention. And that is an evidence-based statement that we can tell our patients that for many is transformative. And so I think that the slowest uptake of that type of acceptance has actually been among providers, and that's been our experience in our clinical settings. And so really supporting the data that there are no other studies that I know of for HIV prevention that have zeros across the board, not even the PrEP trials. So this is a statement that CDC has put out. Many jurisdictions have also sort of signed on to this. City and County of San Francisco has done so as well. And I like to also highlight condom effectiveness. I think there's a lot of approach for supporting condoms, and condoms are an important tool for people to use, but their efficacy and effectiveness among heterosexuals is about 71 to 77%, and then among MSM, it was about 70% effective. So this Jade's article in 2015, I think one important insight to this is 100% condom use. This is not 99, 98, or 95. Because if there was not 100% condom use, this is all self-report, it was as effective as not using condoms at all. And so when we think about what somebody's perception of their risk is, 95% versus 100 doesn't seem like a big difference. But in the clinical trials that were used to devise these data, it actually was associated with no protection in HIV acquisition. And then the last point I wanted to make about this is there's still a lot of desire to counsel individuals. So in the absence of PrEP, counseling about risk reduction does not work. Does not work for MSM, does not work for heterosexual individuals. There's both observational and now randomized controlled clinical trial data that when you provide counseling for risk reduction counseling alone did not reduce subsequent STI acquisition, and that for MSM in the study called AWARE that was published in JAMA, there was actually a 15% increase in STI acquisition for MSM. So not only does it not work, it actually might be doing harm for MSM. And so I think it's a study I like to highlight because I think it shows that we have this attachment to doing some things that might actually not be working. And then when we look at, this was a study that was presented at CROI, not this past year, but the year before, that PrEP use actually among HIV negative partners of our patients in our HIV clinics is actually quite low. And so we've made the effort to try to encourage our patients who are living with HIV, if they have HIV negative partners, to refer them in actually as a sort of peer referral in for our clinic for accessing PrEP. So I think we have this tremendous unmet need in a population that potentially our patients whose partners are uninfected might be able to access. And for U equals U, the question comes up as like, are you actually you? And this is data that was presented in CROI and looked at self-reported versus actual viral load data among men who stated that they were undetectable, and that 53% of those who said that they were undetectable actually were undetectable versus the remainder who actually were not, based on dried blood spot. So I think that it gives us some pause around engagement in care and the impact on self-report versus actual viral load data. All right, so case 5. This is a 28-year-old HIV negative woman who's in a serodifferent relationship with HIV positive man. He's newly diagnosed and not yet stably viral suppressed, and they want to have a baby. So what do you recommend? Wait for the male partner to become virally suppressed for 6 months. Use PrEP, it's safe periconception and in pregnancy. Don't use PrEP, its safety is unknown. Use sperm washing instead, or do something else. Great, so 65% say use PrEP, it's safe periconception. 32% would wait till the partner is virally suppressed for at least 6 months. So I'd just like to highlight the fact that HIV risk increases during pregnancy. So these are some data from 2,700 HIV-infected women in Africa who are in serodifferent relationships and were followed through 2 different HIV prevention studies. They had frequent testing for HIV as well as pregnancy, and similar to the U equals U studies I showed, they linked genetically the HIV infections. And so the graph on the right, I just wanted to highlight, in the black is those who were non-pregnant, and then in the light gray to darker gray, it actually goes from early pregnancy to late pregnancy to peripartum, and that it's compared to non-pregnant women, early pregnancy was associated with higher, and then that risk actually increased over time, and that even after conception, the risk of HIV acquisition actually continued to rise. And so I think really appreciating that it's not just the process of conception, but actually ongoing risk that many of these women are going to be at if their partners are not virally suppressed, and that using PrEP throughout the pregnancy is actually likely going to be necessary in order to prevent subsequent acquisition even after the periconception period. So safety in pregnancy has become a big question. So there has been limited data, but this was a study of 30 women who became pregnant while on PrEP compared to 96 women who were not exposed to PrEP. There was no difference in miscarriage, congenital anomalies, or growth through 1 year of infancy, and that there were slightly lower Z-scores for length and head circumference early on, but non-significant at 1 year. I think with a lot of the concern about the role of dolutegravir and neural tube defects, I think there's going to be a lot more review of data as PrEP has been rolled out in demonstration projects, but we don't have any evidence that PrEP is associated with TDF is associated with worsening birth outcomes for pregnant women. So we do offer PrEPception, so use of PrEP around periconception, but also highlight the need to often continue this beyond the delivery, because even in the postpartum period, if the partner is not virally suppressed, that's actually the highest risk for subsequent acquisition of HIV. All right, so case number 6. So it's a 35-year-old MSM in a serodifferent relationship, comes in seeking PrEP. He states his partner has been unsuppressed and he's just starting a new regimen. He had a change in his regimen because of resistance, and he's pretty sure it's M184V. He doesn't like condoms, so what do you recommend? They should continue to use condoms until the partner is virally suppressed for at least 6 months. You prescribe TDF or TAF. You prescribe 3-drug PEP, or you do something else. So 60% of people were comfortable prescribing TDF or TAF, about a quarter would prescribe PEP, and 12% would suggest continue to use condoms, and 4% something else. So there are breakthrough infections that happen in PrEP, even at 99%. With the number of people who are starting PrEP, we expect to see some failures or PrEP breakthroughs. Now, I think one of the things that has happened in the community is that when individuals have had this sort of breakthrough PrEP, breakthrough infections, that there's been a lot of public shaming of those individuals, that they actually just weren't taking it, that this was bad adherence, and that PrEP actually is 100% and never fails. So these are some data that have looked at adherence measures that showed high adherence. So this was in Lancet HIV 2018, and the one at the top was the case that was reported in that study, and there was high levels by both DBS and hair, segmental hair analyses, and that the trials, the cases below those, one of the commonalities is actually the M184V. And I think that there can be some debate about whether that's emergent resistance, if somebody has a breakthrough infection and is on TDF-FTC, that M184V can arise pretty quickly. But I think that in the context of these other mutations that are there, that there's likelihood that these are transmitted infections, and particularly the one at the top that actually was mapped to a case in the San Francisco area who had the exact same resistance, and there was sexual contact about 2 to 3 weeks before this person was diagnosed. And so it raises the specter of how do we manage PrEP in the situation when a patient's primary or partner, for example, who they would know about, has an M184V. And so we don't have any great guidance on this. This is something that we encounter, thankfully, relatively infrequently, but it is somebody that I would offer PrEP with TDF-FTC, and or potentially offer PEP early on if this person is going to be, primary partner is going to be virally suppressed quickly. So I think this has to take a patient-centered approach in management, but I think PEP would be an option in addition to PEP. All right, so case 7, this 29-year-old woman in a serodifferent relationship who would like to stop using condoms. Her partner is not virally suppressed, and she wants to know how long she has to take PrEP before she is protected. What do you tell her? 3 days, 7 days, 21 days, 28 days, I have no idea. So 45% suggest, I wanted to say this looks like the middle finger that Dr. Zag was talking about yesterday. 21 days, about 45% versus 7 days. So there's some data that, so the PK, so these are all based on PK data that is looking at, how long does it take for levels to reach concentrations that have been associated with protection in peripheral blood mononuclear cells, which would be the targets for HIV infection. And so at about 7 days, you achieve about 89% in PBMCs and about 98% by the 13th dose. So it's about 14 days. And so given that we know that other PK data suggests that rectal tissues have 100 to 10 to 100 fold higher concentrations than in vaginal and cervical tissue. The recommendation for MSM is approximately 7 days and then continuing at 28 days after based on these PK data. I think that the IPERGAY data suggests that these correlates of likely protection might not actually be accurate, because if that was the case, then the IPERGAY regimens would not work. They were only taking it for 2 days afterwards, but they did have a loading dose, and so that was higher than is sort of standard what we use. So currently for women, it's recommended for 21 days, but we're sort of working towards a consensus that 7 days might be adequate, but that there likely needs to be more higher adherence to maintain high levels of efficacy compared to men, with 4 to 7 days doses for men to have protection and 6 to 7 doses for women. So I think that our bottom line is that we suggest 7 days for men and 21 days for women, but that likely is an overestimate of the length that it actually takes for somebody to be protected. So switching to case 8, this is a 35-year-old woman, a transgender woman, who reports that she has infrequent condomless sex and is reluctant to start PrEP because she believes that it will interfere with her gender-affirming hormones. How do you counsel her? You tell her we have data that PrEP does not affect hormone levels and encourage PrEP. You tell her we don't know if PrEP affects hormone levels, but still encourage PrEP. You tell her we don't know if PrEP affects hormone levels, nor do we know if it works for trans women, because there have been few trans women in trials, and encourage condoms. You recommend 2-on-1 PrEP, so she has less PrEP exposure. So 66% said would tell her that we have data that PrEP does not affect hormone levels and encourage PrEP use. So I think that that is the correct answer. And there have been several PK data studies of trans women, comparing them to MSM, and the bottom line from the small studies that have been done, there's 2 additional studies that are ongoing. Hope to have some data for, probably presented at CROI or IAS next year. But essentially that PrEP does not impact hormone levels among trans women, and that hormones do reduce PrEP levels, but only slightly, and they still maintain above what we estimate to be the protective levels. And so it's about a 10 to 30% decrease in PrEP levels that we see with gender-affirming hormones in the trials that have been done so far. This is an example of one of them that was done out of Johns Hopkins. And so these are for daily PrEP, so we have no idea of how this might impact those who are on-demand PrEP, so 211, because exposure is likely going to be lower in 211, and we don't know that if that reduction that you would see from gender-affirming hormones might negatively impact efficacy of 211. So this is what we use to counsel trans women who are interested in PrEP if they don't want to start daily PrEP, because it is something that for a lot of individuals who don't want to take a daily pill, 211 does offer another option. So in IPREX, there were about 339 participants who identified as trans women, and similar to MSM, if there was detectable tenofovir in the blood, there was no infections among those women. However, detectable levels was actually quite low at 18% among that group, and that many trans women expressed concerns about these interactions. And I think this is an interesting question as we try to answer this, because this came from the community, this came from trans women who expressed these concerns, and now that we're starting to get some of the data to answer those questions that have been raised to us. And then, as I mentioned, there's several studies that are going on. Hopefully we'll have additional data in the next couple of months to support PrEP uptake among trans women. All right, case 9. So you have a 31-year-old patient on PrEP who comes in for his routine quarterly lab tests. His 4th-generation antibody test comes back positive, but the confirmatory test and viral load come back negative. What do you do? So you repeat the test, but continue PrEP as you assume the 4th-gen was false positive. You repeat the test and stop PrEP, but start ART for acute HIV infection. You repeat the test and stop PrEP until you can determine what the infection status is, or you do something else. Great, okay, so have a spread here. So 40% would repeat the tests and stop PrEP and start ART. About 36% would repeat but continue PrEP, and 21% would stop PrEP and repeat the tests so you can determine what the HIV infection status is. So all 3 of those options are things that we encounter quite routinely when we have these false positive tests. And so just a recap of the FEBIG stages, and so from acute infection, where you would have a negative HIV antibody test and a viral load, and after about FEBIG 2 to 3, you start to have antibodies develop and detectable on some of our more sort of 3rd and 4th gen antibody tests. So this is how we approach ambiguous HIV test results among our PrEP patients. So this is adapted from John Michel Molina, who gave a presentation about this at CROI. So with the quarterly HIV PrEP screening, we have a positive screening test, and we want to confirm the presence or absence of infection by repeating the test. So we use serologic testing and RNA testing, and we actually recommend using another manufacturer's test for that repeat testing if that's available. And then how do you manage any antiretroviral drugs? So there are three primary options. You can continue PrEP, particularly if they were adherent. It maintains protection, but actually increases the risk of resistance if somebody actually truly is infected. You can stop PrEP, which would facilitate the diagnosis, but you actually, if they aren't infected and they're still at risk, then they might actually acquire an infection during that time when they're off PrEP. And you could start ART, but you might have drug-related AEs. I think this is less of an issue with our highly tolerable regimens now, but it might make confirming the diagnosis more difficult. So we've gone down all three of these depending on what the patient preferences are. So I think a lot of this is actually driven by the patients and how comfortable they feel with either abstinence, if you're going to stop PrEP to reassess HIV status, and the risk of what that diagnosis might have for them and what it might mean for them if you start ART and plan to continue that ongoing. And so I think that however you get to that decision about whether to continue PrEP or stop PrEP, but I think all these are options, and that just because you have a positive HIV test doesn't mean that you have to stop PrEP. Just a reminder that there is a CDC PrEP line, which is available during the day for sort of help adjudicating these cases. So we get cases from all over the country. There's actually a case in DC of exactly this, and the decision actually was to stop PrEP as they try to assess the HIV status, because that was what fit best for the patient. So I'm just going to turn to a little bit about the future of PrEP. What is most exciting to you about the future of PrEP? Long-acting injectable cabotegravir, long-acting injectable rilpivirine, oral FDA or MK-8591, broadly neutralizing antibodies, vaginal rings, or Maraviroc. Great. So the here and hopefully very near future, when we have injectable cabotegravir for treatment, seems like the most exciting. So just to recap some of the future of PrEP, of what's going on. So we have the dapivirine ring studies, which are working their way through the European equivalent of the FDA for approval. So they showed early efficacy of the dapivirine ring. In the trials, it was about 30%, but in the open label extension, it's actually higher. This is the prevention efficacy that we often see, and this has been seen in PrEP as well. And there's a evaluation of multi-purpose technology, so combining PrEP with contraception and anti-STD, and then looking at some rectal douches as well, which are under development. The long-acting ART options include cabotegravir, which is being evaluated in 2 large trials in the HIV Prevention Trials Network, HPTN 083 and 084. I think that there is no magic bullet, I think, is the bottom line about all of the PrEP approaches. So this is for individuals who, if it shows efficacy, it does require taking a daily pill for a period of time. There is this very long pharmacologic tail that actually seems to be longer in women than in men, and can persist for well over a year, and that there may need to be other agents and other methods of delivery, including implants, which might be able to be removed, and the MK-8591 is one of those options that's being evaluated for sort of implants. So looking at HIV vaccine, I think this has been some interesting, exciting work in the clinical trials. So there's 2 efficacy trials now in sub-Saharan Africa. There is one trial now. Since I submitted these slides, they've actually started enrollment. The first enrollment was actually in Houston of an Ad26 HIV vaccine. And so there is real hope that if one of the trials in sub-Saharan Africa, for example, shows efficacy, that it would be approved by the regulators in South Africa. And then passive vaccination with monoclonal antibodies is being evaluated. There's a large efficacy trial in sub-Saharan Africa and one in North and South America called the AMP trial that uses broadly neutralizing antibodies that are infused or injected. We were a site for this trial, and I think there's a lot of concern up front about whether this is focused on MSM and trans individuals. So it's one of the first trials that's actually open to trans men. And there was real concern about whether people would actually come in and do this. And universally, it was there was so much interest in it that we almost ran out of study product. So they actually had to slow the trial down because there was so much interest in the community for this. And I think a lot of it was driven by the availability of PrEP and people's engagement in prevention. But I think that we can't presume to know what people want because people are often interested and excited about new opportunities and new things for prevention. So these are some of the implants, and so there's the implant on the upper left, and then there are some microneedle delivery systems that are being evaluated as well. And so I think that there is going to be new options. We need to really think about this in the same way we think about birth control, is that, you know, the pill, oral contraceptive does not work for everyone, and that people want options, and that for PrEP, as we develop new delivery methods and new drugs that are available and show efficacy for PrEP, that we give people the options to start with one, change to another, and then change to a subsequent one later that might fit better in their life. So I'm either out of time or I'm not working for advancing. Oh, there we go. There we go. And so these are just some of the benefits of sort of the implantable devices versus oral dosing, which you can see in purple. The doses go high above what we would hope would be the sort of safety targets versus the implantable devices in green, which sort of stay in this sort of sweet spot right in between sort of not overshooting the safety targets, but staying above the efficacy targets, and that some of the subcutaneous or IM injections actually also peak. And so just really highlighting the advantages of using an implantable device compared with oral dosing. So at that, I will end and be happy to take any questions about any of the PrEP cases, or didn't spend a lot of time on TAF FTC versus TDF FTC, but happy to answer questions about that as well. Great, thank you.
All right, before we get started on the questions, I neglected to mention in the initial announcements that it was actually Ryan White's birthday today, would have been 48. So lots of questions already, but if you come to the mic, I'll start with the cards that we have here. First question, do you treat TAF FTC with 2-1-1 dosing? Can you use?
So we have not been using TAF FTC for 2-1-1 dosing. I think we We don't have the data to support that it would be useful, but I think now that we have the DISCOVER trial data that show that it's equivalent to TDF for daily dosing, we don't currently recommend it because we don't have the data, but I think that I would think that it would work just as well, but we can't, that's not an evidence-based statement, so we don't really offer that.
So you've not used that in that setting?
No.
Yeah. So there's a couple questions regarding, first of all, no cis women in the DISCOVER trial.
Mm-hmm.
And so the question is whether you would consider TAF-FTC for PrEP to protect receptive vaginal sex.
So that's something that I would have a conversation with my patient about, and I would highlight that we don't have the data to support that that TAF-FTC has not been tested in women. However, we would expect from the PK, given that you have higher intracellular levels, that it should provide protection as well as TDF among women. Gilead, I know, did submit some PK data to the FDA to have that indication. It wasn't ultimately accepted by the advisory panel as sufficient. So I think that if it's between nothing and TAF-FTC, I think that's a very different conversation than if somebody is asking if they can switch from TDF to TAF.
Well, that's actually the next question. Do I need to switch my PrEP patients from TDF-FTC to TAF-FTC?
So I think in general I would say no. We have we've actually come up with guidance, tried to provide some guidance. The safety data is that TAF-FTC and TDF have similar safety profiles. And I think that suggestions that TAF is safer than TDF has not been shown in the clinical trials. You have a very small difference in the creatinine clearance change with TAF compared to TDF, but that there's not it's not a safer drug in terms of clinically relevant events in any of the prevention trials, and that it's going to be generic in probably mid-next year, and that there's going to be a tremendous difference in the cost associated with it, and I think we generally shy away from considering cost, but I try to encourage my patients that we have a lot of safety data with TDF, and then I remind them about the weight gain, and then that usually ends the conversation.
All right, we have a question at the mic.
So adolescent access to PrEP is a state-specific scenario, but can you speak to adolescents who are on their parents' private insurance and how they might access it?
Yeah, so this is a huge challenge for young people, as they may not be out to their parents, and as I saw somebody actually on Monday, who wanted to access PrEP. His parents know that he's gay, but actually think that he's still a virgin. And so he didn't want that disclosed to his parents by being on PrEP. So it's not just about coming out, but it's also about sex and all the complexities of talking about sex with your parents. So in California, for example, we have a state law now that precludes insurance companies from sharing that information, the explanation of benefits, with a primary holder of that insurance. And so I think that that's one example of a policy that was very helpful in supporting adolescents. Now, that isn't enforceable, and there are penalties if that happens, but if that happens to a young person, then that can be very traumatic and problematic. So what we've done with some of the resources in San Francisco, actually, we've purchased Truvada, and we have a youth emergency fund where we give it to them for free, because until we can get all these things worked out, because we were seeing diagnoses among young people as we were trying to get them access to PrEP, and this was a huge barrier for them, and all the details hadn't been worked out yet.
Who funds the emergency fund?
We bought it, the San Francisco Department of Public Health.
wanted to just throw out the idea that maybe 340B funding could be allowed for that specific use, in terms of just trying to think of ways in which all of us can access PrEP for teens.
And I also think that the Gilead Medication Assistance Program that is now sort of being supported by CDC, like I think I would also advocate that that should be a special carve out for young people under the age of 26 to be able to access this for free, regardless of insurance, because they do technically have insurance, but that does not mean they have access.
Do you have any strategies for retaining patients? We have a much higher loss to follow-up compared to our HIV-positive patients.
Yeah, so we have, in many of the trials, actually, there's been PrEP persistence or continuation is about 50% at 6 to 9 months. And so in most clinical settings, a lot of people get lost very quickly. And I think a part of it is that, if you are accessing this for prevention and not for sort of disease-specific care for HIV, like you're going to have a different threshold for how much of the hassle of going through the medical system you're going to deal with. And I think that's what we're seeing with PrEP. When we interview our patients who sort of get lost. So what we try to do is create as much flexibility as we can. So we have navigators that work with our patients, and so I tell them, if I have a 27-year-old who has no other medical problems, he doesn't need to see a physician every 3 months. Like, he can come in and get his labs. I can talk to him about any clinical concerns. But most of his needs are going to be around adherence and support, and so that can either be done on the phone or via other staff who might be in the clinic. So just encouraging and requiring them to come in for testing every 3 months, but then all the other visits actually happen remotely. And we're capitated, so it's not that there's a loss, a financial loss to the clinic as a result of using that strategy, but it actually supports individuals for meeting sort of their needs in a way for prevention that I think our standard healthcare systems just don't do for prevention. And then for young people, I think there's some studies from the Adolescent Trials Network that showed that every month visits and counseling was actually associated with much higher adherence than the more standard adult-oriented 3 months. And so we created more intensive support for young people because they are going to be the epi data, that's where a lot of our infections are happening and where a lot of the needs are and these unique barriers that are not addressed in many clinical settings.
Great. Question?
Okay, I think you just kind of answered my question. Do you have any ideas, thoughts, strategies in terms of getting more young African American MSM at risk on PrEP? We know they have the lowest uptake right now.
Yeah, so So I think that the conversation about reaching young Black MSM and young Latinx MSM comes down a lot to like, who is the messenger, what is the message, and where are people going to get care for PrEP? And I think that the message has not been directed towards young Black and Latinx MSM. I think a lot of the PrEP discussion, I think this is what we're seeing for trans women, is that PrEP was for white gay men, and PrEP is for gay boys and not for trans women. So these are the messages that we're sending out through the ads, through the campaigns, and who is represented in those campaigns, who is talking about PrEP in those campaigns. And in our community, a lot of the PrEP uptake actually was not providers. That was early on, providers saying, oh, we think that you might benefit from this. A lot of it was actually people talking to their friends and partners. And in some places in San Francisco, it actually became, oh, I want to get on PrEP because all my roommates are on PrEP and all my sex partners are on PrEP. And then it became, I need to be on PrEP because nobody will have sex if I'm not on PrEP. And so it really was this engagement within the social and sexual networks that drove it. And that has not happened with African Americans. It has not happened with Latinx, particularly MSM. And, in many ways, this is all predictable. Like, this is a new intervention. It's got high efficacy, but it's got high barriers, right? This is not like just HIV testing, where there's been a lot of community-based approaches. This is all within medical settings that already have disparities, already have barriers, and that we're overlaying this into that where somebody doesn't actually need to come in for care. This is all about prevention, and so the thresholds are going to be lower for dealing with some of those things. So I think it's an opportunity to reset and rethink how we approach it, because we are going to worsen the disparities. We're seeing this in San Francisco. The majority of our infections now are among African Americans and Latinx individuals, even though our numbers are going down. So we might achieve towards our ending the epidemic, but we might worsen the disparities as a result of it.
Thank you.
Next question.
So I have a similar concern with regards to my African American women. I have several that have had the STDs. Clearly they're at risk, and I get a frequent report of, well, I've talked to my friends about it, and we've heard there's bad things with that drug. Your slides regarding the safety of it in pregnancy, the slides regarding the safety period are helpful. Have you engaged strategies to engage that group of individuals who have an increasing HIV risk?
Yeah, I think one of the things that we really need to focus on is, talking to the individuals who might be sending these might be able to distribute these messages, to engaging with individuals. So, I know that several colleagues who are doing work sort of through qualitative interviews and doing ensuring that the messenger who's sending the message is a trusted voice. And I think for a lot of MSM, this has been their trusted friends and families who have access to that information that not all the folks who would be having this discussion have access to. So one of the things that we did, and we do a lot of online activities, so we were in like a forum, online forum, talking about PrEP, and like the stigma and this, like, we call it slut shaming around PrEP for people who are sexually active, was coming from the community, and there was community efforts to check that. But without access to the information, people don't necessarily feel like they have the tools to counterdict what's being said. And also medical mistrust. We can't forget, when I do community work, Tuskegee comes up every time.
Yeah.
It comes up in different contexts, but like people have a lot of reasons not to trust the medical system, and we don't do enough to to counteract that, to address it head on, and to frankly ensure that things like that don't happen in small ways when people come into clinics.
Okay.
And in a community with a low incidence of HIV, but a very high incidence of other sexually transmitted disease and lots of hepatitis C and lots of IV drug abuse, what level of incidence would you start treating these people with the high-risk behaviors?
With the high risk of what?
With the high risk of transmission, like the high-risk multiple sex partners and IV drug use?
At what level would I start treating?
Yeah, we don't have very many HIV positive cases in our community,
Okay.
but it's not zero either. And there's just a wildly high level of risky behaviors, and I don't know where to jump in.
So is the question when we would treat somebody for...
When you'd start using PrEP, like if you're seeing clusters of new infections, or do you...
So I've been an advocate of, I said this at a meeting with CDC, and they didn't really like that. I said it, but I think one of the biggest ways to address some of the stigma is just I said offer PrEP to everyone. So the idea of offering it to everyone, and perhaps maybe just doing education where you educate everyone about it. Because I think that we are really poor at really recognizing the risk that somebody has, and individuals are also are not very good at self-assessing their risk. And so I think offer it to everyone. And I think we're doing more harm by not getting it to the people who need it than getting it to some people who might not need it, because they might need it later. and we won't know that. And they often come to our attention after that's happened. As we know, people start and stop PrEP without telling any of their providers.
So we'll start Monday.
Yeah.
So one more question, if it's very quick.
I guess kind of quick. So I actually agree with you, PrEP for everyone. I would put it in the water if I could. So I live and work in a more rural environment, and access to PrEP doesn't necessarily start with infectious disease. It starts with primary care physicians. And what I found is patients have to go through multiple barriers in order to even get to someone who would prescribe it. So I've actually started a research project on educating the community about PrEP. But what other ways would you engage primary care physicians and really get them on board with the process of PrEP and HIV prevention?
So I think one of the things that I found providers respond most to is cases and examples within either their specific clinic or cases, examples that are very familiar to them about somebody who was diagnosed with HIV, had multiple contacts with either primary care provider or some other healthcare system, had no discussions about PrEP, may have had a positive STI. And those, I think, are some of the cases that we try to use to try to encourage providers to support PrEP. And there are a lot of barriers that are not just about clinic visits and about other things like stigma. There was a presentation at the National HIV Prevention Conference that the biggest factor associated with willingness of nurse practitioners to provide PrEP was religious affiliation. That didn't matter which religion it was any religious affiliation, and that we still have patients in our clinics who get stigmatized, the ICD-10 codes that say high-risk homosexual behavior. There's a lot of those barriers as well. So really sort of taking that holistic approach with providers. And I think a lot of primary care providers don't have this as their purview. And I think that this is the population, this is the group of providers within Ryan White that I think should be providing PrEP, that PrEP should be part of the Ryan White care opportunities for people, because all the barriers for people who living with HIV many of them have been worked through for the clinical side of things, and that this is a missed opportunity to not really expand it greatly within Ryan White.
I think I have to stop here. I apologize.